Good day, students. I'm Mrs. Olajide Adetunmise. Today we shall be looking at the topic antenatal care. Antenatal care. And under antenatal care, we shall be looking at all the activities that you are expected to do under the antenatal care as a midwife, the aims and objectives of antenatal care. We shall look at the prenatal test and screening, and finally we shall be looking at focused antenatal care. Focused antenatal care. Antenatal care. What do you mean by the term antenatal care? Antenatal care refers to the care of a pregnant woman. Ante means before, natal birth. That is the care that you give to a pregnant woman before what? Before birth. And it is a clinical assessment of both the mother and the fetus during pregnancy. You want to ensure that both the mother and the fetus, or maybe fetuses, they are fine. Traditionally, it involves a number of routine visits, like 12 to 16 times, for the assessment of the pregnant women before and during pregnancy. What are the objectives of antenatal care? Why do you want women to come for antenatal care? The first objective is to maintain the health of the mother and the fetus during pregnancy. You want to make sure that both the mother and the fetus or fetuses are in adequate state of health and that there is no problem. Another objective is that you want to identify high-risk cases. You want to identify high-risk cases among the pregnant women that are patronizing you as a woman, as a midwife, so that appropriate intervention can be taken in order to prevent complications throughout the pregnancy. And you can achieve this through your physical examination to assess. During the process of assessing the pregnant women, you can note those people that are at high risk, and through health education too, you can do that. Then another one is that you want to teach the mother about the child care. You are not going to be waiting until the woman delivers before you will now be explaining to the woman on how to take care of a child. So you want to teach the woman during the period of pregnancy on how to take care of the baby, nutrition, sanitation, and hygiene. Different countries have been using several approaches to antenatal care. Some countries use traditional approach that involves about 12 to 16 times. The woman visiting the antenatal clinic for 12 to 16 times during the pregnancy. There are some that make use of focused antenatal care. Some countries make use of goal-directed antenatal care. Why there are some countries that develop their own approaches to suit their own circumstances. So it depends on the country in which you are practicing. As a midwife, there are some activities that you are expected to carry out for a pregnant woman that is visiting your clinic. A pregnant woman has come to your clinic now that she is pregnant. Maybe the uterus is yet to be protruding. You want to check whether the woman is positive or not, maybe at the early stage. You can do that by testing the urine. Sometimes you can make use of blood tests to test for pregnancy, and ultrasound can also help you to determine that. So the activities that you are expected to carry out during antenatal care. It is highlighted as I've seen on the screen. History taking, examination of the patients, routine test, prenatal test, then later we are going to be looking at focused antenatal care. But majorly, you want to take the history of the patient, you want to examine the patient, you want to carry out some tests, prenatal test inclusive. For example, in women that have a history of previous chromosomal abnormalities, that have given birth to previous chromosomal or that have given birth to babies with chromosomal abnormalities, you may want to carry out prenatal test in order to detect that. Or in women that is older than 35 years, then you want to carry out other routine tests. We are going to be taking it one after the other to explain that. To start with, we are going to be starting with history taking. What did I call it? History taking. Okay. History taking during antenatal care. The first one that you want to know about your patient, you want to take the demographic variables, the demographic attributes of your patient. The name of your patient, where does she lives, her age, what's her occupation. All of these things will be pointing you to some things. For example, during the process of taking the demographic data of the patient, you are able to determine that the patient is older than 35 years. It's pointing you, maybe that was the first pregnancy. It's pointing you that this patient is an elderly primate. Some information will be passed to you. You want to know the occupation of the patient. Occupation will help you to know, at least to determine if the patient is financially stable or not. So you want to obtain all those demographic data of the patient and her family. The next the next point that you are expected to do under the history taking is you want to ask for the history of the last normal menstrual period. You want to ask the patient if the patient have a normal and regular menstrual cycle. You want to ask the patient when she last have a normal menstrual period. Sometimes it may be difficult for the patient, but you want to assist the patient. Maybe you want to link it to maybe a festival that happens maybe in the past. Was it okay during the Christmas period? You want to use that. The LMP, you need to use the LMP to calculate the EDD, the expected date of pregnancy. And you have been taught how to use the LMP to calculate the expected date of pregnancy. Another history that you want to obtain is a past obstetric history of the patient. The past obstetric history of the patient. It is very important for you to know how many pregnancies the patient has lost. You want to know the history of abortion. Maybe the patients have had some form of a threatened abortion in the past. It will be pointing you to something, and you want to take an appropriate intervention in order to assist the patient. Most of the time, the patients may often forget about miscarriages and ectopic pregnancies, but you want to remind them because they are part of what you should calculate as part of the pregnancies that the uterus has carried. Sometimes they may not want to tell you about the previous pregnancy that they have had. maybe from another husband or from their previous boyfriend. You want to remind them because you need it. It is very important. You need to ask questions about all those things, about the number of pregnancies, the number of ectopic pregnancies, miscarriages, the number of children that are alive. You want to note it. The number of those children that have died. You want to know it, and you want to know the cause of the death. You want to know the history of the death, whether the death was before or after delivery. You have to obtain all those data. As part of the past obstetric history, you want to obtain the birth weight of the previous children. You want to know, do they have a low birth weight or not? Do you remember that low birth weight may be pointing you to that maybe that baby that was born previously was a preterm baby, or it can be an indication of growth restriction. And in an heavyweight baby, it may be alerting you that possibly the mother may be having diabetes. So that's a reason why you have to obtain all those information, all those data. They are very, very important. And then you want to obtain the approximate period of gestation. You want to note the period of gestation. You want to ask about the episode of hospitalization during the previous pregnancies, and you want to note the reason. Why did they admit the woman during the previous pregnancies? It will be pointing you to some things. Then, if there is history of a previous admission, you want to know the number of hours, the number of days that she was admitted. And when she was in labor in previous pregnancy, how many hours does it take her before she was able to deliver the baby? Does she experience prolonged labor? You want to know the type of delivery that she has. Maybe it's a normal delivery. Maybe she was assisted during the delivery. Maybe she was delivered through cesarean section. You want to look at all of those things. Does she has a form of prolonged labor as a result of cephalopelvic disproportion? You want to note it. You have to ask for the reason. For example, if the patient was delivered through cesarean section during the previous deliveries, you want to know the indication for cesarean section. Was it as a result of maybe the patient has a gynecoid pelvis? It will be pointing you to some things on how to go about the care of the patient. Then you want to note the information about the types of incision that is made on the uterus during the previous cesarean section. Was there any complication during previous deliveries, such as preeclampsia? Maybe the mother has gestational hypertension, gestational diabetes, obstetric or sphincter injury, that is third or fourth degree tears. Does she has a history of postpartum hemorrhage and history of impacted shoulder? You want to note all those things because it will assist you to provide appropriate care for the pregnant woman. You want to know if she has an history of assisted reproductive therapy, such as stimulation of ovulation with clomiphene. Maybe she was assisted through IVF or all those things. After obtaining all those information, documentation is very important in nursing. You have to ensure that you document all those findings. Those are the findings, those are the information that you have to obtain under the past obstetric history of your patient. That will take us to the medical history and drug history of the patient. You want to ask for history of maybe she remember any medical comorbidities that are most likely to affect her during pregnancy, such as asthma, cystic fibrosis, maybe she has epilepsy, diabetes, hypertension, and the rest. The history that are related to her medical history. You want to obtain the history. Maybe she has rheumatoid arthritis, hemoglobinopathies, sickle cell disease, thalassemia, blood-borne viruses, HIV, hepatitis B, hepatitis C. Maybe she has renal disease, heart valve disease, tuberculosis, and the rest. You know, during the process of obtaining this medical history, let me say, for example, if the patient is HIV positive, you know the appropriate drug regimen that you want to place the patient on to prevent mother to child transmission. You want to ask about allergies to medications that may bring any form of problem to the patient. They may not remember, the pregnant women may not remember all of those things, but you want to ask them. You want to ask them all of those questions. Is there any history of drug allergies, so that you will not be administering the drugs? Maybe in case of emergencies, you will not be administering the drugs that she is always reacting to. You will not be administering it to the patient. Another history that you need to take, the history of the current pregnancy. The history of the current pregnancy. You want to ask about the gestational age of the pregnancy, the last menstrual period. You can use that to estimate the gestational week in which the pregnant woman is. The gestational age, you can use the last menstrual period to calculate that, as discussed before. Apart from that, you want to look at the family history. You want to look at the family history. Is there any form of diseases that runs in their family? A family history of type 2 diabetes in a first degree relative is considered a risk factor for developing gestational diabetes. So you want to obtain the history. Is there any kind of illnesses or diseases that runs in the family? You want to use that to develop appropriate intervention for the pregnant woman. Then apart from that, you want to look at the social history. Under the social history, you want to ask the patient about her thoughts of the pregnancy, and you have to be sensitive if the pregnancy is unplanned. You want to ask her about the current or previous occupation. You want to plan for how is she planning to return to work after the delivery. You want to ask about the home circumstances. Who is she living with? Where is her partner living? Are they living together? You want to obtain all of those things, all of those information. You want to inquire about the financial circumstances of the patient and the cost of caring for the baby. You may ask about her history. How does she relate with people in her community where she lives? Does she have the history of smoking or taking alcohol? You want to note that. You want to note, if assuming she has the history of smoking or taking alcohol, you want to ask the patient if she would like to quit, and you want to encourage her to quit smoking or taking alcohol because it is dangerous to her health. Now this is taking us to another subtopic, which is examination of the patient. Examination of the patient. It is part of your duty as a midwife to examine your patient from head to toe. But before you will ask the patient to lie down on the couch, you should instruct your patient to go and empty the bladder. After emptying the bladder, You have to check the height of the patient. You want to check the weight of the patient too. And probably you can test the blood, the urine of the patient to check for any abnormalities such as protein in urine, glucose in urine, and the rest before asking your patient to lie on the couch. You ask the patient to lie in supine position. You prepare all the instruments that you will need for the examination of your patient. You have to prepare all the equipment. Can you tell me the equipment that you need in examination of your patient? Things such as measuring tape to measure the height of fundus, the penile stethoscope for auscultating the fetal heart rate or Doppler, ultrasound gel, everything that is needed. You want to make sure that they are within your reach. So examination of the patients, you want to examine the patient generally, general inspection and appearance. You want to examine the thyroid gland, examination of the breast, the lymph node, the chest, the cardiovascular system, the abdominal examination, and all of those things. You want to do that. So on asking your patient to lie down on the couch in a supine position and with the head of the bed raised to 15 degrees, you want to make sure that your patient is comfortable. Ensure that your patient is as comfortable as possible. Look at the general well-being of the patient. Is the patient at ease or the patient is in distress? Look at the hands of the patient and palpate for the radial pulse. You want to look at the head and neck. Is the conjunctiva pale? Can you observe any form of jaundice or edema? Look at the legs, the calf. Is there any form of swelling, edema, or varicose vein? So you have to do cephalocaudal inspection, examination of the pregnant woman from head to toe. So you want to look at the head, the hair. Does she plait her hair well? Is the hair well plaited? Is it neat? Are there presence of lice? You want to look at the eyes. Is she pale or not? The neck. You want to examine the thyroid gland. You want to ensure that the thyroid gland is not enlarged, and if it is enlarged, you want to document it down and you want to take appropriate steps as concerning that. You want to examine the breast too. The patient must be undressed in order for you to examine the breast properly. You want to examine the breast. Is there any form of abnormality that you may identify, such as condition of the breast, such as flat nipple or fissured nipple, or any form of abnormality that may make breastfeeding to be difficult, and you want to address that too. Apart from that, you want to look at the chest. You want to examine the chest for any form of scars. Is there any form of abnormality of the spine? Is the patient experiencing any form of difficulty in breathing, that is dyspnea? Though I told you about the physiological impact of pregnancy. I have discussed that with you in the previous class on how pregnancy can have impacts on different systems of the body. Though due to the intra-abdominal pressure, that the diaphragm may be pushed up by 4 centimeters, the patient will experience difficulty in breathing slightly, but it should not be too pronounced. During your examination, if it is too pronounced, that means it is pointing you to some things and you have to do something about it. Further examination needs to be done in order to come to a definite diagnosis to plan an appropriate intervention that will assist the patient. Then examination of the cardiovascular system. You want to check the pulse of the patient. Then you want to check the blood pressure. and you have to record it as appropriate. If the blood pressure is too high, it's pointing you to something, and if it is too low, it's pointing you to something. An appropriate intervention have to be done. That will take us to abdominal examination. Abdominal examination. Abdominal examination involves three major things: inspection, palpation, and auscultation. Can we take that again? Abdominal examination during pregnancy, during antenatal care, when you are giving care to the pregnant woman, involves three major things: inspection, yes; palpation, yes; and the last one, auscultation. Inspection, palpation, and the last one, auscultation. What are you expected to do under abdominal inspection? Look at this diagram. You may need to observe for the distension of the abdomen if it is compatible with the gestational age of the pregnancy. If the pregnancy is greater than 24 weeks, you can inspect for fetal movement. You may wish also to look if there is any form of surgical scars, such as previous cesarean section, or maybe where woman have had a form of a laparoscopy in the past. You want to look at all those scars. Then apart from that, you want to look for skin changes that may be indicative of pregnancies. And what are those skin changes that may be indicative of pregnancy? The linea nigra, the striae gravidarum, the striae albicans. You want to look at all of those things. I think you can see that on the screen that you are looking at. Then palpation. You want to palpate the abdomen of the pregnant woman. During the process of palpating the abdomen, you want to ask the patient to comment on any form of tenderness that she may observe, that she may experience during the process of palpating the abdomen. You too, you are going to notice any form of tenderness, and you observe her facial expression. You want to obtain her verbal responses throughout the period of palpating the abdomen. During the period of palpating the abdomen, you want to look at the fundal height. That was the reason why I said during the process of gathering the instruments that you have to take a measuring tape. So you want to determine the fundal height of the woman by using the medial edge of your left hand to press down the cephasternum. Then you walk towards locating the fundus. After doing that, you now measure from the fundus to the symphysis pubis. After measuring it, then you now turn the measuring tape in order to note the measurement, and you have to record it. Under normal circumstances, uterus should be palpable after 12 weeks near the umbilicus. Uterus should be palpable after 12 weeks near the umbilicus at 20 weeks, and near the cephasternum at 36 weeks. Most of the time, when the pregnancy is about 36 weeks, you can palpate the uterus at the level of the cephasternum. Though most of the time, the measurement that we are talking about here can vary based on the height of the woman. That is, whether the woman is tall or the woman is short. Then you want to look at the lie of the fetus. When you want to look at the lie of the fetus, you make sure that you gently apply pressure on the abdomen. Then you move the hands and palpate down the abdomen. During the process of palpating down the abdomen, you will observe that one side will feel fuller and firmer. If you have been doing it on the ward, you observe that one side will be what? It will be fuller and it will be firmer. That part that is fuller and firmer is the back of the fetus. So you can palpate the other limbs at the opposite side. Looking at the picture that you have before you now in the slide, when you palpate that side that is firmer and fuller, you can see it will be that should be the back of the baby. It should be back of the fetus, and the opposite parts to that place where it is firmer and fuller, you can find the limbs of the baby. Then you want to look at the presentation. You want to look at the presentation of the fetus, and when you want to do that, you palpate the lower uterus, that is below the umbilicus, to look at the presenting part. You want to know which part is the presenting part of the fetus. When you are palpating a firm and round object, it signifies a cephalic presentation. That is, the baby is presenting with what? With the head. Can I take that again? A firm and round, when you palpate, and you could observe that you are palpating a firm and round object, it signifies a cephalic presentation. But when you are palpating a soft and not round object, it suggests that it is a breech presentation. So, if a breech presentation is suspected, the fetal head can only be palpated at the upper part of the uterus. Then you want to look at the liquor volume. How can you detect that? You palpate and ballot fluid to approximate volume to determine if there is oligohydramnios or if there is polyhydramnios. How can you detect if the woman is having polyhydramnios? If you have to palpate deeply before feeling the fetal parts, that is, the palpation have to be deep before you can feel the fetal part. It may be pointing to the fact that the woman may be having polyhydramnios. Then another thing that you want to palpate is that you want to look for the engagement of the fetal head. When we are talking about fetal engagement, it refers to whether the presenting part has entered the bony pelvis or not. You want to note if the presenting part has entered the bony pelvis or not. Then, when you are noting that, you have to note how much of the head is palpable. If the entire head is palpable above the bony pelvis, it signifies that it is 1/5. You measure that as 1/5. Then the fetal auscultation too. So this is talking about the fetal engagement. You want to note the part of the head, the presenting part. How much has it gone into the bony pelvis? So if you can palpate all the fetal, the engaging parts above the bony pelvis, that is 1/5. That is what we are trying to explain. You have to urine testing. What are other routine tests that you are expected to write and carry out for your patients? These include the blood group of the patient. Sometimes the patients may need to be transfused in an emergency. That will not be the time that you now be carrying out blood tests to determine the blood group of the patient. So you want to know the blood group of the patient, the genotype of the patient, the rhesus factors. That is very, very important too. You know, the issue of rhesus incompatibility is very serious. Is the patient, is the mother, if the mother is a rhesus negative mother and the baby is rhesus positive, in subsequent pregnancies, if the mother has not been given RH immunoglobulin, there may be problem, because the system of the mother will be producing a form of what? Antibodies that will affect any subsequent pregnancies. So in a woman that is rhesus negative and the baby is rhesus positive, it is better when it is at 28 weeks, when the gestational age is at 28 week, the woman will be given a rhesus immunoglobulin, and after delivery too, she will be given such an injection. Then you want to check the PCV, the packed cell volume of the patient. That one will help us to dictate if the patient is anemic or not, and it will assist towards planning for an appropriate intervention. What about hepatitis B and C, HIV/AIDS, urine testing, glucose challenge test for gestational diabetes, and venereal disease research laboratory? All of those things will be carried out for the pregnant woman. Now we'll be moving to prenatal screening and testing. Prenatal screening and testing. Prenatal testing may be offered to women during pregnancy to determine if the fetus has the possibility to be born with a genetic condition or birth defect. So most of the time, prenatal screening is always done in order to determine if a fetus is at high risk of having some genetic conditions such as chromosomal abnormalities or any other birth defect. So prenatal screening and testing will help to dictate on time, and appropriate intervention will be carried out. What are the indications for prenatal test? When the age of the pregnant woman is greater than 35 years, there are different kind of genetic condition that can occur as a result of, as the age of a woman is increasing. Then if there is family history of a previous child with genetic condition, maybe during the previous delivery, maybe the woman has had a baby with Down syndrome, so you want to carry out a prenatal screening to know if the present pregnancy that she is carrying is having a baby, maybe she's still carrying a baby with genetic disorder or not. Then another indication, in parents that are known as the carriers of specific genetic condition, you want to determine, that baby has an high risk of having that same genetic condition that the baby has. Genetic and hereditary factor, they play important role in what we becomes in life, because it is the gene of the mother and the father. Both the mother and the father will be the one that will transfer the gene to the baby. Then during an abnormal ultrasound findings, maybe during the process of carrying out an ultrasound, the ultrasound reveals some abnormal conditions. Prenatal screening can be done in order to confirm that. Prenatal screening and testing can be done in order to confirm that. And also, any woman that desires more information about the fetus she is carrying can go on to carry out prenatal test or screening. Though the decision is an individual choice, Any pregnant woman that wishes to carry out prenatal screening or test should discuss with her midwives so that appropriate uh, test can be carried out on the types of prenatal screening. There is screening test and diagnostic test. The screening test and the diagnostic test. Screening tests are used to identify women with an increased chances to have a baby with certain chromosomal abnormality. Women that have that has the high risk of having babies with chromosomal abnormalities, screening tests can be done. Results that reveal a chance over a certain cutoff. Results that reveal a chance over a certain cutoff level are called positive results. If after doing the screening test, the result shows that it is above the normal limit, then diagnostic test can be carried out for the pregnant woman. Screening tests, you cannot use screening tests to confirm a condition. But if the screening test has come out to be positive, then you can go ahead to carry out the diagnostic test in order to confirm such a condition. Screening tests can be performed in both the first and second trimester of pregnancy. It can be performed in both the first and second trimester of pregnancy. Example of screening test is the ultrasound and blood test. While example of diagnostic testing is coronary villus sampling, that is also known as what? CVS. And another type of diagnostic testing is the amniocentesis. The coronary villus sampling test. How is it done? How is that done? Okay. CVS is done around 11 to 13 weeks of pregnancy. All they need to do is just to collect a simple sample of the tissue from the placenta, and that can be done by either inserting a thin needle through the woman's abdomen, or sometimes a small catheter can be inserted through the cervix. It depends on the location of the baby and the placenta. So the tissue will be collected from where? From the placenta, and it will be analyzed. Why amniocentesis? That one is performed when the pregnancy is around 15 weeks onward. And during the procedure of amniocentesis, a thin needle can be inserted through the woman's abdomen, transabdominal, into the amniotic sac to withdraw a small sample of fluid around the fetus, and it will be tested. That is how that is done. So what are the health education? What are the education that you need to give to women in pregnancy? You want to educate them on personal and environmental hygiene. You want to educate them on diet, that they should take adequate nutrition and diet. They should eat fruits and vegetables. They should exercise. Simple exercises in pregnancy you want to teach them. You want to also counsel them on the need for family planning after the delivery of the baby. You want to ensure that they carry out appropriate family planning, that they should go for appropriate family planning based on what is appropriate for them. you want to educate pregnant women on danger signs of pregnancies, such as seeing the blood, headache, high BP, edema, protein in urine, all of those things. Dyspnea, insomnia. When they see all those signs of danger signs of pregnancy, they should not hesitate to come to where? To the hospital and lodge their complaint. Then you want to teach them on how to care for their breast during pregnancy, preparing the breast for breastfeeding. Those women that may have conditions, abnormal conditions of the breast, such as flat nipple, fissured nipple, you want to assist them to prepare the breast towards breastfeeding. Then immunization of the woman during pregnancy by making sure that you give them their TT. At least they will have 2 doses in pregnancy. Then you want to counsel them on proper immunization of their baby too after delivery. Then drugs too. You want to counsel them that they must not take unprescribed drug during pregnancy, and all the drugs that you're expected to prescribe for the pregnant women, such as their hematics, their antiemetics, their IPT, intermittent preventive treatments, the use of sulfadoxine pyrimethamine prophylactically. You want to make sure that you supply all those drugs and you encourage the pregnant women to do what? To ensure that they take all those drugs as it is prescribed. It is very, very important. Now, that will be taking us to focused antenatal care. What did I call it? Focused antenatal care. Can we take it again? Focused antenatal care. Focused antenatal care is a form of antenatal care too. It's different from the traditional form of antenatal care. You know, very soon during the course of this discussion, we'll be looking at the differences between the traditional antenatal care and focused antenatal care. The focused antenatal care segregates pregnant women into 2. The first people, there are those people that fit into the basic components of the focused antenatal care. And the second set of pregnant women are those ones that need specialized care because of their specific health condition or because of the presence of one or more risk factors. And focused antenatal care in basic components, that pregnant woman, if she is not having any problem, needs to come for just 4 visits. While traditional antenatal care, the visits can be as much as 12 to 16 visits. Later, we'll get to how we can differentiate between focused antenatal care. We are going to comparing focused antenatal care and traditional antenatal care using some concepts. What was the focus of the focused antenatal care? What was it aiming at? Focused antenatal care is aiming at promoting the health of the mothers and their baby through targeted assessment of pregnant women. It's targeting on assessing pregnant women to facilitate the following. 1. Towards identification and treatment of already established diseases. Focused on antenatal care want to identify some diseases that are present already with the pregnant women and also assisting the pregnant women in treating it. Focused antenatal care also targets early detection of complications and other potential problems that can affect the outcome of pregnancy. It also focuses on prophylaxis and treatment. It focuses on individualized care. That is care that is prepared, that has been decided for that pregnant woman only. Individualized care. The one that you have prepared for Mr. A and Mrs. B is different from the care that you have prepared for Mrs. A, because it is an individualized care. You will have to involve the pregnant woman and her husband towards deciding the kind of care that is suitable for her. That is what individualized care is talking about. And also focus antenatal care focus on birth preparedness. Preparing everything that needs to be prepared, everything that needs to be get set before birth. That is the focus of the focus antenatal care. What are the basic principles of focused antenatal care? It includes thorough evaluation of the pregnant woman. The evaluation will be done thoroughly, from history taking to what? Examination, physical examination from head to toe, the screening, the health education, prophylactic treatment, identification of so many existing conditions, and how you want to prevent complication. So, the basic principles of focused antenatal care include thorough evaluation of the pregnant woman, administering prophylaxis as indicated, prevention of mother-to-child transmission of HIV, collaborative decision-making with the mother. Quality of care is given much emphasis during each visit. Later, we are going to be looking at what we are expected to carry out for pregnant women during each of those visits. Also, in focused antenatal care, no pregnancy is labeled as a risk-free until it is proven otherwise. You know, in traditional antenatal care, they can classify the pregnant women into high risk and risk-free. But in focused antenatal care, in the use of focused antenatal care, you don't label any pregnancy as a risk-free pregnancy until it is proven otherwise. Then, in focused antenatal care, pregnant women and their husband, you see them as what? As risk identifiers. You want to involve the husband in the care of his wife in pregnancy. You want to explain to them, these are the danger signs of pregnancies, so that anytime such a sign is seen, they won't hesitate to come to the hospital. The husband have been involved in the care of his wife. So once he is seeing blood coming from the vagina of his wife, he too, as a husband, will know that this is a danger sign that was discussed with me in the hospital. So he will ensure that he do everything possible to take his wife to the hospital. So focus antenatal care see the husband and the pregnant women as what? As risk identifier. So let's compare the traditional antenatal care and focused antenatal care using the following approach: the number of visits, approach, assumption, use of risk indicators, preparation of the family, communication, and cost and time. So, under the number of visits, the traditional antenatal care, the number of visits will be up to between 16 and 18, regardless of the risk status of the mother, of the pregnant woman, whether she is high risk or low risk. The number of visits is up to 16 to 18 visits. But for focused antenatal care, for women that are categorized under the basic components, all they need to do is just to come for just only 4 visits. How many visits? 4 visits. Let's look at their approach. Under the approach of traditional antenatal care, it is vertical only. Because pregnancy issues are addressed by health professionals, it is only pregnancy issue, one-way traffic. It is only pregnancy issue that are addressed by healthcare professionals. But in focused antenatal care, it integrates other services apart from pregnancy issue, such as prevention of mother-to-child transmission of HIV/AIDS, counseling on danger signs of pregnancy, risks of substance use, HIV testing, malaria prevention, nutrition, vaccination, and all of those things. So focused antenatal encompasses all those things. But the traditional form of antenatal is just a one-way traffic, just focusing on pregnancy issue alone, no more, no less. Under the assumptions, under the traditional antenatal care, more frequent visits for all and categorizing into high and low risk. It helps to detect problem, assuming that the more the number of visits, the better the outcome. That's the assumption of traditional antenatal. That is, it is the total number of visits that a pregnant woman visits the antenatal clinic that will determine her outcome. That is the assumption. That is the belief of the approach of traditional antenatal care. But in focused antenatal care, it assumes that all pregnancies are potentially at risk. It assumes that all pregnancies are potentially at risk, and it's targeted and individualized visits to help to detect problem. While the traditional is saying it is the total number of visits that a pregnant woman visits the antenatal clinic that will determine her outcome. But this is saying no. Focused antenatal care is saying no. It's focusing on an individualized visit that is targeted to help to detect problem. Under the use of risk indicator, the traditional form of antenatal care focuses on risk indicators such as the height of the mother, any height that is less than 1.5, weight that is less than 50 kg, leg edema, malpresentation before 36 weeks. All such women will be labeled as what? High risk women, using of routine risk indicator. But focused antenatal doesn't rely on routine risk indicators. It assumes that risks to the mother and fetus will be identified in the due course. While traditional antenatal care, when is saying indicators such as women with height that is less than 1.50, with weight that is less than all those indicators, be seeing that woman as high risk. But focused antenatal care is saying all those risks will be identified in the due course. What about the preparation of the family? In traditional antenatal care, is the woman solely depend on the healthcare providers for everything. But in focused antenatal care, there is shared responsibility for complication readiness and birth preparedness, because you involved both the husband and sometimes the family towards risk identification. What about the cost and time? The cost and time. A visit that is up to 16 visits as compared to 4 visits you can see that one is more expensive. Traditional antenatal care is more expensive as compared to focused antenatal care of 4 visits. Those are the differences that I want us to note under the comparison of traditional and focused antenatal. What are the important elements of focused antenatal care? Thorough evaluation through history taking, physical examination, and basic investigation, as have been taught under antenatal care. Intervention such as prevention, prophylaxis, and treatment. Prevention, for example, giving hematinics to prevent anemia, giving IPT prophylactically to prevent what? Malaria. Intervention and treatment. For example, if the patient sometimes comes down with malaria, you want to treat the patient. And promotion, health promotion through health education, counseling, and health services that we have discussed during the course of this discussion. And the basic and the specialized components, the components of focused antenatal care. I told you it is divided into how many parts? It is divided into 2 major parts: the basic component and the specialized component. There are some preset criteria that will assist you as a midwife to determine whether a woman will be placed at the basic component or at the specialized component. I'll discuss that now. If at any point, what I'll be discussing after this, a woman give a answer of yes to any of the questions that you'll be asking, that means the woman is not fit to be classified under the basic component. That means the woman will be placed under the specialized component. You want to ask history about the previous pregnancy. As in, did it ended in stillbirth or neonatal loss? The history of 3 or more consecutive spontaneous abortion, a low birth weight that is less than 2.5 kilogram, or a large baby that weighs more than 4 kilogram. You want to ask for hospital admission, maybe for hypertension, for pre-eclampsia or eclampsia. Those are the things, the questions that you'll be asking under history or previous pregnancy. Then, under the history on current pregnancy in focused antenatal care, you want to ask, maybe she has been diagnosed of having twin pregnancy. Maybe in that present pregnancy, she has been diagnosed of twin pregnancy, or she's suspecting it, or she has a high risk of multiple pregnancy. You want to ask for the age of the mother. If the age is less than 16 years or is more than 40 years, you want to ask for the blood type. Maybe the mother is a rhesus negative mother. You want to ask a question. Maybe the mother is having vaginal bleeding or growth in her pelvis. You want to look at the blood pressure of the mother. Is it hypertension or low hypotension? Does the mother have the current history of diabetes, heart disease, kidney disease, hypertension, cancer, or any form of severe communicable diseases such as TB, malaria, HIV, AIDS, or any other sexually transmitted infection? Once the mother gives yes to any of the questions that I've asked now, that means the mother is not fit to be classified under the basic components of the focused antenatal care. Thereby, you have to classify the mother under the specialized components of focused antenatal care. So, what are you expected to do at each of the visits? You know, I told you 4 visits. The first focused antenatal visit, it should be before 16 weeks of pregnancy. And during that period, you want to assess the medical and obstetric history. You want to carry out the physical examination and the tests. You want to test the patient, the blood test, the urine test, every test that I've discussed with you previously. You want to carry out all of those things, and you want to determine our eligibility to follow the basic components. You know, I told you it is either you classify it as under the basic component or under the complicated component. So under the first visit, those are the things that you will be doing. You have to determine the woman's medical and obstetric history. You want to perform basic examination. If the pregnancy is beyond the first trimester, you want to determine the gestational age by measuring the fundal height. You want to provide nutritional advice and routine iron and folate supplementation. You want to provide HIV counseling and prevention of mother-to-child transmission services. You want to give advice on malaria prevention, and if necessary, you can provide insecticide-treated nets. You want to check our urine for glucose using a dipstick test. You want to advise the mother and her partner on the need to save money in case of any emergency, in case she may need referral. So also you want to provide basic specific answer to the woman's question or concerns of her partner. Those are the things you'll be carrying out during the first visit. The second visit of focus antenatal should be between 24 to 28 weeks. In addition to what you have done during the first visit, you need to do what? Measure the blood pressure. You assess the fundal height to determine the gestational age. You review everything that you have done for the mother. If necessary, if there is need to modify our individualized care plan, you modify it. You give advice on any sources of social or financial support that may be available in our community if she is financially handicapped. And the third visit should be between 30 to 36 weeks. In addition to what has been done in the previous visit, you want to dictate if there is multiple pregnancies. You want to give advice on family planning. You want to encourage the woman to consider exclusive breastfeeding for her baby. You want to tell her the advantages of exclusive breastfeeding. You want to decide if there is need for referral based on the updated risk assessment that you do for her. Also, you can review the birth preparedness and the complication readiness plan. You want to review it. Then you want to perform urine tests for the pregnant woman too, to detect any form of abnormalities such as protein in urine. That one will be pointing you to check the BP to confirm if there is hypertensive disorder of pregnancy and so on. That is that about focus antenatal care and our discussion for today. If you have any question, please don't hesitate to inform me. I'll be glad to answer all your questions. I wish you well in your endeavors. Once again, I am Mrs. Adetunmise Olajide. Thank you.